Hi, I'm David Gaba. I'm the Associate Dean for Immersive and Simulation-Based Learning at Stanford University School of Medicine, and I'm a professor of anesthesiology there. I'm also a staff physician and director of the Simulation Center at VA Palo Alto Healthcare System. It's my distinct honor and pleasure today to be able to have a conversation with Dr. Stephen Abrahamson, known as Dr. A. Dr. A was one of the pioneers and inventors of the SimOne simulator in the 1960s, which was a device and a technique and simulator many years ahead of its time. I, like many people, am very grateful for this opportunity to learn more about what you did that was so groundbreaking and what happened to it. So thank you very much for this opportunity.
My pleasure to be here. I'm honored.
Great. So I think the biggest question on many of our minds is, how did you guys think of this back in those days? How did you get involved?
I had just come to USC as the director of a division of research in medical education. My career had turned into, how can I help medical school teachers learn something about teaching and learning so that the results of their efforts can be better than what ordinarily takes place. And I'd been there about a year, and the man came to me and said, I'm an engineer. I work at Aerojet General, and I'm also on a special committee, the Chamber of Commerce, because at that time, 1964, 5, somewhere in there, the engineering firms were losing contracts from the government because the government was saying, let's get the troops out of there, let's not spend money on defense. So his question for me, Tullio Ronzoni was his name, how can you use computers in the medical school? And I said, you know, I don't know much about engineering, and I'm not quite sure what you're asking me. And he said, you know, I've been sent to you by the dean, your dean. If you and I can't work something out, I'm going over to UCLA. Well, that's not something that a guy from USC wants to hear. And I said, well, it occurs to me that, I remember in those days, the computer at his engineering company took up a room, and they plugged things in and unplugged things, and they made cards with holes in them. And I said, it seems to me that what we might try is mocking up all of the results from the tests that anesthesiologists run while they do surgery. We can have the pulse rate, we can have the respiration rate, we can have the heartbeat, and the trainee, instead of having to get a patient, in this case from the county hospital, a poverty patient, and start to work at that level, he could start with all of the information that an anesthesiologist gets. And then we could control the information and change it. Here's a rapid heartbeat, here's a pulse rate that's changed, here's breathing that looks, and he then has to put his, what I would do next is, and give it to somebody or punch some buttons and get the results. And he said, what a great idea. He said, now you and I have to get to work. I said, hold it. I've been in an operating room twice, unconscious both times. I'm not sure I know what these guys do, except I know that they prevent them from having pain, they prevent them from having trouble. So we then involved Dr. J.S. Denson, Sam was his nickname, and the three of us talked. But then Tullio Ronzoni brought 2 or 3 of his engineers, and we met every Saturday afternoon and talked about this. And I discovered late in my life, it seemed late in my life, now it doesn't seem so late, how people in business do business. They have martinis with lunch. And we would have 2 or 3 martinis, and we began to get the picture of what information would come and how it would be presented. And on one of those days, when we made it to 3 martinis instead of just 2, somebody in the group, 5, 6, or 7 of us, said, why don't we build the whole body? And not one of us could ever remember who brought that idea in. And we all said, what a great idea. So the Aerojet General people, under Tullio Ronzoni, got the Sierra Engineering Company, and they said, sure, we'll make a body. And damned if they didn't come up with a body. The simulator was just tremendously lifelike. It breathed, but when we put the breathing in, the physiology people who were then working with us said, now breathing takes 2 motions, the chest wall and the diaphragm. And Sierra Engineering built that in to our simulator so that when it breathed, the chest wall would go up and down, but the diaphragm would go in and out. Therefore, later on, we were thinking about we can put in some difficulties with that. So it all started with this simulator out at Aerojet General. Somewhere along the way, at USC School of Medicine, we got a computer. And again, it was one of those, but we were able to move the body to our facility and then start doing a lot more. My role was to test the students who were using a simulator matched against students who were not and see if there was a difference. We also had to design measurement or assessment tools so that we could measure their competence. And over time, I got a grant, a couple of grants, from the U.S. Office of Education, and we were able to design measures that we tested in the field, and they were approved, and it did measure. We developed a competence level, but we also could compare groups, and we got the data that this was a way to teach something like anesthesiology. We could, with our simulator, have him develop a heart problem, breathing problems. As he used his laryngoscope, if he pushed too hard, he could break a tooth. Our School of Dentistry designed the entire inside of the mouth, gums, teeth, and a couple that could be broken. And of course, we could put them back. Now, we had a problem with how do we tell when he's injecting something? And the engineers at Sierra Engineering got in touch with a German company, and they magnetized the needles, each needle differently, so that even though we were using distilled water for any injection, we got up to the point where there were 10 different substances that could be identified as the signal went into the portal. And how much came was measured in the portal. And whatever it gave, the computer could tell what's going to happen and then have the simulator do it. Our best public moment came in 1967 when we produced a film of how it works, and I was interviewed by Time magazine, Life magazine, and Newsweek magazine. And that's when it all burst. The immediate reaction from most all of the medical schools in the United States was zero. We got no reaction at all, except personal. And they would say, what are you trying to do, destroy what we do? The answer was no, we're trying to help. We're trying to make things that can make your job easier and more effective. There were a lot of funny things that happened at our institution with faculty rejecting the idea, and they managed to destroy the project. I better not tell all of the details because they're pretty gross. One of them was that the county hospital said, we need space for the hospital chaplain, and we want to use the space that you're using. And the chief of anesthesiology said, sure, go ahead. So we lost the space. And they moved SimOne. Well, they couldn't get it through a certain door, so they cut the arm off. Does this give you a picture of what we were doing? And that was just about the end of SimOne. By then I had gotten involved in another form of simulation, human simulation, now called standardized patients. And Howard Barrows, an associate professor of neurology, was just up to here with the horror of using pregnant poverty patients at the county hospital to teach medical students the neurologic exam. And he got his favorite model, Rosemary. He said, if I teach you the neurologic exam, would you be willing to let medical students try it out on you? Using her to teach the students how to do the complete neurologic exam. And the first article published on the human simulation was 1964. Now, why did I get involved? Because he needed money. And I got a couple grants. This time from NIH. They liked the idea of not using poverty patients, if possible. But then we wrote the first article, and we expanded that. And that one, like the other simulator, wasn't really recognized until years later. Now, what was I skilled in? Getting grants. I worked for a dean during the 60s, mid-60s, late 60s, who called me his $1 million baby because I got to know people and they got to know the quality of our work. And I'm not claiming the quality. I'm claiming quality with my partners as well as what I was able to contribute. And all of that work grew because of the way in which we could go step by step, with research. Anyway, that's the background to what we started to do with money that came from, of all places, the United States Office of Education, because they liked the idea. It was part of training, the improvement of training, and they liked the results as well.
Well, those are some really great stories, and again, we're so thankful that you've been willing to share these stories and to bring this history to life for all of us, because we really value hearing about it and recognizing what groundbreaking and forward-thinking work that you and your colleagues did at a time when it was really unprecedented.
I thank you very much. I'm flattered at what you're doing with this award, and I thank you very much for your attention and for the attention in making me the recipient, and I thank you.